Hello, my name is Elizabeth Miller, and today I would like to talk with you about Alzheimer's disease. Alzheimer's disease is the most common form of dementia, which according to the Diagnostic and Statistical Manual of Mental Disorders is a neurocognitive disease. Currently, over 45 million people in the world have dementia. By 2050, there may be 131.5 million people. Dementia is the leading cause of death in Australian women. Alzheimer's disease is responsible for 60 to 80% of dementia cases, and it's causing years of heartache and exasperation to individuals and their families. Alzheimer's disease presents differently to every person. There are not any two cases alike. However, an elderly person with a steady deterioration in memory-centered cognition could be assessed as having a typical case of Alzheimer's disease. Dickerson and Atri state that such a person might initially present with an assortment of neuropsychiatric and behavioral symptoms, as well as personality changes. They often manifest as difficulties with memory or holding on to new information, being anxious, having sleep difficulties, being apathetic, irritable, forgetting the location of things like keys, forgetting appointments, changes to prescribed medication, uncharacteristic mood swings, and the list goes on. It can be very exasperating for the person affected and for family and people close by who observe this, have to live with a person like this or work with a person like this. And people wonder, what is the reason for that? Is that just a scatterbrain? But the underlying pathological reasons for this could be damage to the medial temporal lobe structures, especially the entorhinal cortex and hippocampus, as well as related parietal memory processing regions. Language issues might be observed, like aphasia, where a person's ability to express and understand written and spoken language is hampered, or agnosia, the loss of ability to identify objects or people, or apraxia, the exasperating inability to pronounce the words the person wants to say. The pathological reasons for these language issues are due to the dysfunction of left frontoparietal temporal cortex. Damage to the pathways in the medial temporal lobe might cause visuospatial malfunction, causing the person not to recognize obstacles, stumble over and bumping into them, spilling things, causing disorder, damage, accidents, and distress. The person might develop compulsive, obsessive, or unacceptable behaviors, increasingly struggle with activities of daily living, facing disability and the loss of independence. There might be uncharacteristic disturbances to executive function, personality, and later in the disease progression, motor systems. Something as simple as the inability to focus on a task which previously was done with ease. There might be amnesia, increased anxiety, acalculia, the inability to add up simple numbers. Behavior, mood, and personality might change. The person might withdraw from friends and family, displaying a lack of interest in previously cherished activities. The pathological cause might be insufficiencies in parietal and frontal regions of the cortex. A collection of some of the above-mentioned manifestations might be attributed to the diagnosis of probable Alzheimer's disease. However, only a post-mortem examination will dispel all doubt. Our post-mortem conceivably may show no abnormalities apart from the nervous system, various pathological hallmarks of Alzheimer's disease might well be evident, such as the accumulation of extracellular amyloid plaques due to misfolded amyloid beta peptides and intracellular neurofibrillary tangles due to hyperphosphorylated tau. Secondary changes in the cerebrospinal fluid and blood might be observed. Atrophy of the brain, as in the entorhinal area, hippocampus, amygdala, and associative regions of the neocortex and the limbic lobe structures. Ventricular enlargement of frontal and temporal cortices and atrophy of the gyri, while the primary motor and somatosensory cortices in most Alzheimer's diseases remain unaffected. In isolated cases, the APOE gene, a contributor to amyloid beta peptides, might be detected. Please note that the brain on the left is from a person with Alzheimer's disease. It is smaller or atrophied compared to the one on the right from a person who did not have Alzheimer's disease. What contributes to brain atrophy? Dickerson and Adri, 2014, state that decades before clinical symptoms manifest, Alzheimer's disease starts due to biochemical, neurophysiological, and neuroanatomical changes. Over time, synapto and neurotoxic forms of amyloid beta peptides accumulate due to inflammation and the microglia's immune response, which disposes of identified synapses and neurons. Neurotransmitter abnormalities, mitochondrial dysfunction, and oxidative stress result in hyperphosphorylation of the microtubule stabilizing protein tau and the formation of tangles. This causes synaptic and neuronal mayhem, leading to cortical dysfunction and possibly to microvascular injury, which results in the shrinkage of gyri and the widening of sulci, especially in the temporal, medial temporal, frontal, and parietal lobes. Terry et al. 1981 adds to the above list of possible reasons for brain atrophy in Alzheimer's disease the reduction of large neurons, especially in layers 2 and 5 of the neocortex. Please take a look at the mitophotographs of Alzheimer's disease brain sections showing intracellular neurofibrillary tangles and neuritic and diffuse plaques. In summary, the cognitive decline in Alzheimer's disease results from the loss of synapses caused by processes such as amyloidosis, tauopathy, and inflammation. The most accepted of several theories about the causes of Alzheimer's disease is that amyloid beta peptides produce increased plaque deposits, which instigates neuronal havoc. Dickerson and Adri, 2014, state that neither blood test for biomarkers, in example in cerebrospinal fluid, MRI or PET scans, nor genetic tests can replace the laborious and complex cognitive tests on which a clinical diagnosis of Alzheimer's disease rests. Only an autopsy can produce 100% proof of Alzheimer's disease, and by then, presentations of mixed vascular pathology and small vessel disease are common in older patients, they say. In the meantime, many individuals and their loved ones will agonize over the insidious changes they observe, fearful of what the future might hold, hoping for a medical breakthrough in the diagnosis and treatment of Alzheimer's disease. Thank you for your attention.